Yes. So, if you are from Birmingham, you understand the map. And so we are somewhere here in the nearly middle of Birmingham. We have moved to a wonderful new hospital called the Midlands Metropolitan. You can see it here. Well, the colour I don't fully like, but it's a very, very lovely place for our patients to receive treatment. We operate patients in the Midlands Metropolitan, but we also travel to Walsall, Good Hope, Heartlands, and the Women's Hospital to see patients with all sorts of gynecological conditions, gynecological cancer conditions. So we then bring our patients for operations to the cancer centre at the Midlands Metropolitan, and then chemotherapy will be performed in the locality. So that's who we are. That's the Birmingham Gynaecological Cancer Centre, a very fancy name. And what we do is we are one of the largest centres in the country, and possibly in the kind of better performing ones. One of them. We do nearly 500 major operations a year. These are all major cancer operations. Ovarian cancer service is one of our gems. That's what we are really proud of. But also we've got very advanced vulvar cancer service. We've got the robot. We've got laparoscopy. You can see that we talked about this term HIPAC. You might have heard about this heated chemotherapy bath into the belly. So we are the only service in the Midlands. Derby is setting it up. For the whole Midlands, we are the only service running this technique. And we are very well supported by the Queen Elizabeth Hospital Medical and Clinical Oncology team with the chemo and radiation therapy. And last but not least, we are a very advanced academic centre. Thanks for this to Sudha, Professor Sundar, who's our professor of gynecological oncology and leads the efforts of research in gynae cancer. And we train the future generation of gynae cancer surgeons in our centre. We are one of the most productive and successful training centres in the country. So that's who we are, and that's our hospital. So shall we talk about ovarian cancer? Pretty sure you know a lot about this, and I just try to have some of the basic numbers and knowledge about ovarian cancer. Ovarian cancer, as important as it is for us, and this is in our mind from Monday till Sunday, this is a rare type of cancer compared to breast cancer or bowel cancer, lung cancer. Ovarian cancer is not a frequent cancer. As you can see, ladies have around 2% lifetime risk, so out of 100 ladies during their lifetime, 2 will have the chance of developing ovarian cancer. So this is a rare cancer. And until kind of recently, research-wise, I think this was not the most focused area of research. I think breast cancer was much more popular. And until recently, when new medications came into the market, and I think research in ovarian cancer has really sped up. So, how does ovarian cancer develop? Why does it happen? To be honest, we should call most of the ovarian cancers tubal cancers. As you may know the anatomy, that's the womb and the cervix. And between the womb and the ovaries, there are 2 tubes, fallopian tubes. And most of the typical types of ovarian cancers, they start developing in the tubes. And the tubes will grow little tiny abnormal cells, and then unfortunately they will turn into cancer cells. And the problem with this tube, that this tube is an open structure to the belly. Okay? And unfortunately, these cells are free to float into the tummy, and hence the reason it's a very difficult disease to catch at an early stage, because there isn't a boundary, there isn't a gate here to stop this process. So, hence the reason we call them ovarian cancer, but it can come from the ovary, it can come from the tubes. And you can see that unfortunately, these cells can go around the belly, and we can find these lumps around the tummy. So you might have seen, this staging, how far the cancer has spread, and we stage the cancers according to their progress. If they are confined to the ovaries, it's just stage 1, 2 when it's found in the pelvis, 3 when it's found in the tummy, and 4 when it's even further spread. What we need to also understand about this cancer, this is a surface cancer predominantly. So these cells can kind of walk around the belly, and on the surfaces they can get attached to any organs. Usually, when patients ask me that, so is it in the liver? I said, no, it's on the liver. It's basically stuck on the top rather than in. Of course, there are cases where the cancer spreads directly into something like nearby bowel, or sometimes it spreads into the bloodstream, and it can be found in distant parts of the belly, like the liver, or spreads through the lymphatic stream, and we can find them in the lymph nodes. So that's how ovarian cancer spreads. So it's usually found on the surfaces most of the times, and that's why we do scans to make sure that they are only on the surfaces, and that's how we tackle it surgically. We try to shave these lumps of any organs in the belly. When any, we say definitely any. So we've got 101 different organs inside the belly, and unfortunately we can find these cancer lumps in any of the parts of the belly. But there are 4 predominant places in the belly. You might have heard about this omentum. It's a very difficult thing to imagine. I always say it's like a pizza dough. It is like a fatty pizza dough, and it's hanging off the stomach. It's like a protective apron inside, and that's the #1 site of cancer to spread, so we always remove this. Next one is unfortunately the bowel, because it's very close to the ovaries. Then, because the fluid in the belly, for all of us normally, circulates like this way with the large bowel, how the large bowel passes the stool through. This water in our belly will circulate, but unfortunately cancer cells from the pelvis can then kind of move upward with this flow, this stream, and we can find, very often we can find cancer lumps on the diaphragm. Diaphragm is the big plate of muscle dividing our chest and the belly, and it's all covered inside with a shiny layer, like I call it like a cling film layer, and we can peel this cling film off the diaphragm, the liver, and other organs surgically. So that's how and where cancer of the ovary usually spreads. How do we treat ovarian cancer? Is predominantly 2 main ways. One is the knife, the other one is obviously the infusion or the tablet therapies. So chemotherapy therapies and surgical treatments. Few kind of strange terminologies to understand. When somebody is offered a staging operation, it means that there's a lump on the ovary, and we don't know whether that lump is cancer or benign or something between, and we like to figure it out, but we also would like to remove it. We like to cure this condition, then we call it the staging operation. This operation is for patients with a lump in the ovaries, no spread usually found around. And in this case we do a hysterectomy operation, sometimes bowel operation. We have to take some parts of this fatty apron, this pizza dough tissue as well. The other operation, which is the more frequent one for ovarian cancer, is this debulking surgery you might have heard, or other terminology, cytoreductive. It's very technical. This means that anything visible we would like to remove from the tummy, and sometimes from the chest even. And this means that we perform a hysterectomy. That's the bare minimum. Obviously we remove the fatty apron. Very frequently, 1 in 3, we have to remove segments of the bowel. The spleen, I always call it as like a big tonsil. sitting in the belly up here. We can live without the spleen. You know, it's not infrequent to have car accidents and the spleen ruptures and it is removed, and people can happily live after without the spleen. And then this peritoneum layer is the shiny layer, which we very frequently peel off of any organs, including the diaphragm. And our aim is to remove everything we can from inside the belly. So in Birmingham, we are very proud that 8 out of 10 patients coming to our theatres, we are able to remove all cancer. It's a very high number. So the next one is bowel resection. I know that whenever I talk to patients, bowel resection is one of the very kind of sensitive spots, because we just don't want to live with a stomach bag. And I completely understand this. And whenever I talk to my patients, I always talk to them as if they were my mothers or my sisters or my daughters. I always try to figure out what if I was sitting in that chair. I'm talking about stoma and bowel resection. These can be very, very harsh topics, and patients understandably often suffer during these conversations. I'm sorry. I haven't had any fluid this morning. I'm a very bad boy because I don't drink enough in the hospital. So, bowel resection means that we remove a segment of the bowel. We've got a lot of bowel in the belly. The large bowel comes from the right here, where the appendix is, and it goes like this, okay? And this is the end. The small bowels, they come from the stomach, and we've got like a couple of meters or so or more bowels, and then it will end in the large bowel. So most frequently, understandably, this part of the bowel is involved because that's where the ovarian cancer is arising from. And when we remove that part of the bowel, we always aim to join the bowel ends back together. But sometimes we feel that it's risky. The patient is unwell on the table, or we have very, very extensive surgery. In such cases, we offer our patients a stoma bag. Very important that before the operation, we have to tell all the scenarios, all the options, because we don't know which one is going to happen during the operation. And very often, patients are overwhelmed by the information given during the consultation about an operation. So that's why I always try to really gently choose my words about these stoma bags. Sometimes, rarely though, we have to remove all the large bowel. Very extensive disease can impact of multiple segments of the bowel, and then we end up with a ileostomy, which is an end of the small bowel coming to the skin, and obviously stool going into a bag. The difference is that obviously the colon, what it does mainly, it does absorb water. And therefore, if you don't have this colon, then the stool will be much more liquidy, and then you need to take some medications to kind of thicken the stool up. So, stoma can be temporary and permanent. Permanent means that you're never going to go back and try to rejoin it. A colostomy can be reversed. But clearly, that's another fairly major operation. So whenever we can, we always try to join it back there and then during the operation. Lifestyle after bowel resection. Obviously, I've never had, fortunately, a stoma bag, but when I see my patients, 6, 12, 24 months after the operation, they are all usually settled with the stoma bag. And very often they don't want to have another big operation. And I always say that there are multiple, when you are on the street, you don't even know who's got a stoma bag. Very, very likely you've got at least, a dozen people around you in the square when you walk around, and they have a stoma bag, but you're not aware of this. So patients' feedback is that you can have a reasonably good lifestyle managed with a stoma bag. Of course, it's not the same as without the stoma. We appreciate that. So we are almost done. Timing. Sometimes we offer the patients an operation up front. So the first thing is an operation, and then we give all the chemotherapies, and then, whether it's possible or not, some tablet treatment like a maintenance therapy. But sometimes the cancer is far too extensive, or Our patients are not very well, they are exhausted and they feel really, really poorly. And if they can't take these sometimes 6-8 hour operations on well, then we start getting them better by giving chemotherapy first. So strangely, giving chemotherapy, which in the mind of the lay people, it's a very toxic medication. Strangely, our patients with ovarian cancer get much better with chemotherapy. Somehow we beat the cancer, we push the cancer underwater, and the body starts kind of revitalizing. Then patients usually come back and they are ready for a major operation. And then we complete the chemotherapy, and that's how we treat usually 6 out of 10 patients in our center. Outcomes are fairly similar. When there is a lot of cancer, they did studies, and the oncological outcome is similar, so there was no difference. But if you operate on a patient who is poorly and weak and frail, obviously you'll have much more complications associated with the operation, there's no doubt. The healing is not going to work well. So, patient selection, we always tell our patients which options seem to be the best, and we always tell the patients the no treatment option. This is legally, we are legally obliged to tell you that if you don't give any treatment, that will happen. And we take into account, how fit our patients generally. If somebody had 3 strokes and 2 heart attacks, regardless, we will possibly take a very, very kind of gentle approach to treat this cancer. If somebody has got lots of water in the belly, that this ascites can be one of the manifestations in the beginning. Unfortunately, that can exhaust patients, and they often are not fit for an operation, so we go for the chemotherapy route. Age, we are not ageist. We do operations on 80, even 90-year-old ladies. But clearly, if a body served 80, 90 years, that body will respond to stress differently compared to a patient at their 60s or 70s. So these are the factors we take into account when deciding on which one would be better, the operation first or the chemotherapy first. And I would like to point out my esteemed colleague's work. The soccer study, Professor Sundar set this up, and we compared centers with different kind of skill set or approach, philosophical approach to ovarian cancer. Centers like Birmingham, where we are very proactive, so to speak. Okay, I don't want to say aggressive because we are very, very kind of meek people. Okay, we are not aggressive, but our approach is very, very proactive, and we have selected centers whose approach is possibly less less confrontational, so to speak. And we had different patient groups, obviously, and those patients who had massive big operations, a year after the operation, their quality of life was the same to those patients with a lesser operation. So big operation doesn't mean that your life will be ruined. And our experience is our patients after massive operations, they come back to clinics 2-3 months after, very well recovered and back to normal. So don't be discouraged when very major operations are discussed. That's basically the message. And let's talk about the last thing, why surgery is important. Surgery is important because this is the one and only factor affecting ovarian cancer patients which we doctors can have an influence on. So the age, we can't change it, okay? Or the genetics of the cancer, we can't change it. The fitness, well, we can help a little, but we can't change it fundamentally. But how well you are able to remove the cancer, it greatly depends on the doctor's, the surgeon's skill set. The second one is this major surgical intervention I tried to describe to you has been proven to improve outcomes. So this is the one thing which can really prolong the life of our patients, and hence the reason the quality of surgery is extremely important for ovarian cancer patients. I don't like showing these graphs. All you need to know is that if you are able to remove the cancer, The outcome is better if these lines are higher, okay? And you can see that if you remove all the cancer, the outcome is much better than if you are unable to remove the cancer. So sometimes you are beaten by the disease and you are unable to remove. Even the best ever surgeon can't remove certain cancers. But there is a difference between surgeons and their skill sets. So in Birmingham, we are very proud that we have been pushing boundaries and we have trained generations of surgeons to perform well in this matter. And also there is good evidence in the literature, in our literature, that if you're operated in a larger center, in a center where this operation is done every week or every day, then the outcomes will be better. And it's very clear, if I do this operation every week, every day, then I'll be much better than if I did them once a month. Okay, I think that's a no-brainer. And in fact, the trial Professor Sundar ran, it clearly demonstrated, and this was a very, very critical trial, it clearly demonstrated that centers whose approach is a little bit less enthusiastic, I have to choose my words well because they are recording me, where the approach is surgical, is possibly less proactive, the outcomes were worse. So I try to gather, what's the key elements of surgical success we should think about. Obviously, disease sometimes can beat the best surgeon, there is no doubt. But how your philosophy is, how you approach this cancer, what's the training you received? Do you do 3 of these a month, or do you do 10 of them? It's a different. It makes difference. Institutional circumstances, where you've got support, a liver surgeon if you can't do liver operations, or a bowel surgeon if you are unable to do bowels. If you don't have these around you, I'm afraid your outcomes will be worse in your institution. Financial factors, unfortunately, I don't want to talk too much about this, but you understand that there is no unlimited set of resources in the NHS. So, the last bit is the heated chemotherapy. We are very proud that we have performed now the first good set of operations on our patients. We set with the HIPAC treatment. This is basically a treatment when we inject into the belly, not into the veins, like in the clinic, by the oncologist, but into the belly, because it's a surface disease. So we inject this infusion into the belly and it's hot. Why? Because heat kills cells, generally speaking, cancer cells especially. Strangely, the hot chemotherapy does even better. It's more effective if you heat up the chemotherapy. But even hot water could kill cancer cells, we know this. And also, if you understand, we give chemotherapy and then we've got a good gap without chemotherapy, because we have to wait for you to recover for the operation, and then to recover from the operation, there's going to be a 6-8 week gap without chemotherapy. So likely, we just give this extra missing treatment into the belly, and possibly that's why it is a helpful treatment. That's how it looks like. That's the only picture I dare to bring, okay? Because I did not want to frighten you. But basically, you can see that there's a machine. The machine is connected to our patient. There are 2 tubes which flushes the fluid in, and 2 tubes which takes it out, and it circulates quite in a high speed. I don't know whether you can see it from there, but there are people who do this open, and they can see it circulating, and there are the ones like us, we do them closed. So we just do a closure, and then the circulation is done in a quite neat way. There is no spillage. Our theatre team is much more satisfied with this technique because it sounds and seems safer for them. We're using quite high, 42-degree treatment. It's an hour and a half extra treatment. And yes, please.
Are you awake for a sec?
Oh no! You are completely asleep. This is part of it. Oh, it's a good question. Yeah. Because you get the chemotherapy and you are chit-chatting, so it's a very, very good question. No, we do this when the patient is still under the influence of the medications and intubated. This is part of the operation. and it adds an hour and a half, 2 hours to the whole process. So that's basically.
I was thinking, because if you can wiggle whilst it's pushing around, it would be there.
Well, we can wiggle it ourselves, you can press it, but the machine is very clever and it can do the circulation really well. So the two things we are anxious of when giving this cisplatin, the name is cisplatin chemotherapy. You might have heard about the carboplatin, which is given as an infusion. Cisplatin is the old version, and that's kidney toxic and toxic to the ears. So we have to be careful that we only select patients with good kidney functions, and also we now realize that every second patient has got a degree of hearing loss. We never asked, but now we're asking, and it seems that we have patients who's got hearing loss, and if we give this cisplatin, we are afraid that they will lose the hearing completely. Just wanted to share with you, okay, we are very proud and we are presenting in the upcoming British Gynae Cancer Society meeting, scientific meeting in June in Bristol. We've done 17, okay, so it's not thousands. We've done the first 17 cases and we have not had any major complication apart from one of our patients who lost her hearing after this treatment on one ear. And subsequently she admitted that she forgot to tell us when we asked. So it happened. So now we ask 3 times, are you sure? And if somebody says, what doctor? No HIPAC. So we just have to be very careful because we don't want to harm our patients. But to be honest, I would appreciate after this presentation if you could guide me. What would you like to sacrifice? Maybe a little bit of a hearing. Would it be within the remit of this treatment? Would you say that, look, you know, you talked about colostomy and talked about this and that. I mean, a little bit of hearing loss, you know, I can't stand my husband talking to me anyway. So, we are going to explore whether this should be a no-go zone, so we should not give it, or this should be like part of the negotiations with our patients. We don't know, and we would need support from you to tell us what would you choose if he told you that you could lose some of the hearing. This treatment cannot be given if you get the operation first. There is no evidence it would help. We can only give it when we do chemotherapy first, and then in the middle we give an operation. So it already halves our patients who are eligible for this treatment. Okay? And then we always know what sort of subtype we are dealing with, so we will know which patient could be considered, and then we have to see if they are fit. So that's why, you know, you start with 100, then it's 50, and then you end up with 17. So because you have to be selective, you can't give this treatment without evidence. So that's why we haven't done hundreds of them. I suggest, you know, that when you see a surgeon, you should ask a few questions and be brave, be prepared as well. You know, you should ask the question that, you know, do you offer surgery for all patients? You know, because there are centres where the patients, the proportion of patients who are offered surgery is not really high. In our centre, it's 6, 7 out of 10 patients we offer surgery, which is much higher than the national average. And then you should ask a question that, oh, I heard about this, you know, that aim to remove all the cancer. So what's your number? You know, here in Birmingham, we do like 80% of patients have complete removal. And then other questions should be like, you know, is this or that type of surgery, is liver or bowel surgery, is it available in this hospital? You should ask, you know, about the strength of that service. And then obviously, if this HIPAC, one can ask you about the HIPAC. It has been proven to greatly prolong life. This is a unique treatment which gives great advantage for our patients. And then there are other measures of surgery, you know, how many patients suffer major complications or so, how many of these operations you do. So feel free to ask questions when operations are discussed. And I just would like to express my gratitude that I have I have been I have worked in a team where we all supported each other, and this is the 5 consultants who work together. Teju is our freshest addition to the team. She just finished her training, and she's going to be the future, hopefully the future of this cancer center. You can see Professor Sundar there, Ms. Singh in yellow, Mr. Kanangara, and obviously myself. So this is the gynae cancer team, and we've got our 4 nurse specialists, CNSs, who are equally committed and dedicated to help our patients, especially patients with ovarian cancer. So thank you so much for your support and being here.